Hello and welcome to Herts Essex Fertility Center Open Evening. Today is Wednesday, the 21st of June, 2023. My name is Mr. David Ogutu. I'm a consultant gynecologist and medical director here at Herts Essex. With me this evening, helping with the opening presentation with the Open Evening is Mana Max, who is our marketing manager. Jackie Hibbert is one of our nurse fertility specialists. And Sadie Barnett is also one of our admin assistants. We'll have a presentation. At the end of the presentation, we'll provide a virtual tour of the clinic. There will be question and answer sessions. So we'll use the bar, the question bar to keep pinging your questions as we go along. But of course, if there are any common theme questions at the end of the presentation, I'll be able to answer those as well. We value your feedback. It helps us to not only continually improve our open evening presentations, but also our service. So if there are certain aspects of the presentation that was not clear enough, or aspects that you would want to have covered a bit better, or positive feedback, then all of that will be welcome to continually improve our service. So a brief history of Herts Essex Fertility Center. This clinic was founded as the Essex Fertility Center in 1989. It was initially based at Holly House Hospital, but we moved to this purpose-built premises in 2007. So we've been in this purpose-built premises for over 10 years, going towards 20 years now. We have the clinic has been running for over 33 years now. We weigh over 7,000 babies, going towards 8,000 babies born following fertility treatments here. We are a standalone clinic, so an independent clinic. All the procedures and all the treatments are provided under one roof. So we're not a satellite clinic referring bits to other clinics. Everything is under one roof. We have a state-of-the-art purpose-built clinic with the latest advanced technologies available in 2023 to optimize our patients' experience and success rates. The services we provide include fertility assessment, so fertility tests for both male and female fertility tests, intrauterine insemination or IUI, IVF, ICSI, PICSI. We provide a fertility preservation service, so we have an egg freezing program, sperm freezing program. We have sperm as well as an egg donation program. We are the UK's largest surrogacy treatment center. We provide early pregnancy ultrasound scan and early pregnancy gynecology service until 12 weeks gestation. We've got gynecology screening test sets available and some gynecological treatments and genetic treatments as well. So as I said before, we've got an egg donation program. So egg donation will be either because of advanced maternal age or early menopause, chemotherapy, or poor quality eggs. Sperm donation, we've got for single women, same-sex couple, female couples looking for donor sperm, and also heterosexual couples who need donor sperm. We have a sperm bank, but we also work with external and overseas sperm banks to ensure that your choice of sperm donor is available to you. We do provide fertility assessments here. We have a one-stop fertility assessment service where all the fertility or the latest fertility tests can be provided in a timely fashion. We have a quick egg reserve test. So for women looking to assess their egg reserve, we provide something called an anti-Mullerian hormone or AMH test and an follicle count, which is performed via ultrasound scan. We provide detailed 3D assessments of the uterus to assess implantation potential or for recurrent miscarriage cases, and saline infusion sonograms, Hycosi procedure to assess fallopian tubes, semen analysis, and we provide midi-fertility female assessments. And these services are available throughout the week. Male and female fertility are different in one way, which is that men continually produce sperm over time, But with women, women are special. They're born with a set number of eggs and they don't make new eggs going forward. So average baby girl is born with about 2 million eggs. Half of those eggs are lost in childhood. But when you get to 12, 13, when women start to ovulate, most girls will have somewhere between 500,000 to 1 million eggs. And these eggs are almost all asleep or dormant. But at the start of every cycle, a few eggs are woken up. And if we perform an ultrasound scan, we'd normally see an ovary with several potential eggs being woken up. We call them antral follicles. These are the potential eggs recruited at the beginning of that cycle. And in the natural cycle, only one of these grows on to ovulate, and the rest will normally die off. When we're younger, we have lots more antral follicles and lots more eggs, and these eggs are also younger. So at 20, we've got 20-year-old eggs. At 30, they're 30 years old. At 50, they're 50-year-old eggs, and the numbers diminish over time. This is a schematic representation of genetically normal eggs. The main determinant of producing a live, healthy baby is the quality of the eggs. So the eggs have got to be genetically normal. When we're younger, we've got lots of eggs, and these green dots represent genetically normal eggs, so we got them in abundance. If we randomly recruit a bunch of eggs, we're likely to have lots of genetically normal eggs there. But as time goes by, the egg numbers diminish. So if we look at an ovary, as we're approaching the menopause, we've only got one antral follicle, but also the green dots are far between. So time is of the essence. The younger we have the tests, or the younger we can start trying for our babies, or preserve our fertility by freezing eggs, the better the chances of success. So our fertility assessment program is designed to do exactly that, which is to pick up any potential problems or pick up solutions in a timely manner and give us the best possible chance of success. Following couples or individuals presenting to the clinic to have fertility treatments, the first port of call, if not having the fertility assessments, which is for those looking to have fertility treatment, the first port of call is normally to call in and book for a consultation. The consultation starts with a pre-assessment visit where they have basic checks such as identification, AMH blood test, thyroid function test for the women is checked, blood pressure, and all of that is assessed. We get make arrangements for a semen assessment on that day. There are forms to be filled in online, which we will send you the details for to fill in online in advance. So when you come into the clinic, most of the demographic data is already in place. And normally takes about another week or so to be able to get you in for a formal consultation with a consultant. At that point, we will have the results of the female's blood test, we'll have the results of the sperm test, and then you can have a full consultation. For those who've had tests or investigations done at other clinics, either at your NHS hospital or privately previously, or any gynecological treatments or tests, then we'd recommend that you bring them in with you so that the consultant has got time to look through them and discuss them in full with you at the consultation. If the tests that have been performed that we don't have to repeat again, then we will not repeat them. We'll be able to use what has been done previously, if applicable. We use an online communication system called Salve app. So we'll give you details of the app to download onto your phone. The Salve app is an appointments reminder. It's got a secure messaging service, a medication manager, and provides all robust medical information that you require in the course of your treatment. This was the first clinic in the UK to use the Salve app. It was developed in collaboration with this clinic, and it makes a huge difference to our patient experience and ease of communication, but also ensuring that there's no medications missed. Fertility and fitness go hand in hand. So not only to optimize the response to the medication, optimize the chance of success, but of course, we're hoping for a pregnancy for all our patients. And your fitness as you get into the pregnancy has got a big influence on the health of the pregnancy, which is the mom's pregnancy, mom's health, as well as the baby's health. So we have a Fitness for Fertility program. We work with a fertility specialist dietitian, and we'll be able to guide you for those who need more information to get yourself in the best possible shape for the pregnancy, and that minimizes the risk of problems such as blood pressure problem, diabetes in pregnancy, and also problems in labor. Following consultation and deciding to have fertility treatment, you'll have a treatment information appointment with a nurse specialist who will take you through all the consent forms. Fertility treatments, especially IVF and IUI, surrogacy, egg donation, ICSI, regulated by law in this country. So there are specific consent forms that need to be signed. So we've got to go through all of that at that appointment, make sure the right consent forms are in place for the treatment, for the egg collection, for the fertilization, for embryo storage before the treatment starts. So it's usually about an hour's online appointment, and you'll get a detailed treatment plan sorted out. For some treatments, such as using donor sperm or donor eggs, or for those looking to donate eggs or sperm, then we recommend counseling. For some cases, it's recommended. For others, it's mandatory. So that's got to be done before the treatment starts. Counseling is availed to all our patients who need it at no cost to the patient as well. We perform detailed ultrasonography to assess the uterus and ovaries and make sure that there are no issues that may affect fertility or may affect the stimulation before we start. If there are, we resolve them before the treatment starts. So as a standard, we perform something called a 3D saline infusion sonogram, where we will be getting a 3D scan of the womb to make sure that we can confirm normal womb shape. We assess to make sure there's no lesions such as polyps or fibroids. So it's a 3D saline infusion sonogram with a tiny bit of fluid inside the cavity of the womb, and it can show that there's a polyp here that would affect implantation. It's sitting here almost like a contraceptive coil. Following a pregnancy, for those who are likely to implant, it also increases the risk of miscarriage. So by ensuring that we've ruled this out before we start the treatment, we're giving you the best possible chances. But of course, if there is any of these problems, then within the clinic, we're able to resolve it for most of our patients to speed your access to your treatment. We provide a reproductive surgery service. So we provide a hysteroscopy service within the clinic for other surgeries, such as open surgeries for things like fibroid removal, or for those who need keyhole surgery for endometriosis or tubal assessments. Then for those, we've got links with a local private hospital where the surgeries are performed. But for simple hysteroscopic procedures, which is to look into the cavity of the womb and resolve polyps, scar tissue, septums, then that's available within the clinic. By the HFEA code of practice, there's mandatory screening tests that have got to be done before we start treatment. These have normally got to be done within 3 months of having a first egg collection or first treatment. So the clinic would provide the test for you. Of course, if they've been done previously elsewhere within 3 months, and we can confirm they've been performed at a UCAS accredited laboratory, then we'll accept your test results from elsewhere. So treatment options we've got include intrauterine insemination. Intrauterine insemination is whereby we would time our ovulation and inject sperm into the uterus. This would be either partner sperm in a heterosexual couple. Heterosexual couples would only be recommending IUI or intrauterine insemination in those in whom exposure to sperm is, lack of exposure to sperm is the cause of their infertility. So heterosexual couples who have problems such as female vaginismus, male impotence, or severe premature ejaculation. The reason why they're not getting pregnant is sperm is not being able to reach the fallopian tubes, then IUI is indicated for them. For heterosexual couples who were able to have regular and protected sexual intercourse with ejaculation within the vagina, then IUI does not increase the chances of success beyond what they're doing at home. So in those cases, it will not be indicated. For single women using donor sperm, same-sex female couples using donor sperm, as well as for heterosexual couples who need donor sperm, then that's an option as well. We do have a sperm bank here, so most of our patients who need donor sperm will be able to access it through the clinic. But of course, if they're looking to import sperm or to use it from specific clinics, or occasionally people have got a known sperm donor, then we'll be able to facilitate that. Egg freezing is increasingly becoming not only popular, but much more common. And the reason for this is there is lots more awareness about the impact of female age on fertility. So society is getting fairer, and women have got more opportunities than they had in the past. So they've got more opportunities in education, in the workplace. So some may not be ready to have a baby as yet because of where they are with their education or careers. So one of the options available is to freeze eggs, so that should they have difficulties getting pregnant naturally in future, or should they want to come back and use the frozen embryos, the frozen eggs at a future date, they've got a better chance of success. So, for example, at 28 years of age, if a woman froze her eggs and then she had difficulties getting pregnant, even at 40 or 45 or 50, if she came back to use her 28-year-old eggs, she would have the same chance of success as if she was 28 years of age. And that's because the womb does not age. The womb's pregnancy carrying capacity is the same in our 20s, 30s, 40s, 50s. It's the eggs that get fewer over time and get older over time. The most clinics in the world now use frozen eggs as their source of donor eggs. And the data we've got from not only our clinic, but clinics around the world is showing that success rates with the current modern freezing technologies are very, very good. It is similar to the chances with fresh eggs. So at the moment, we're seeing lots more people freezing their eggs because it's more accessible, but also the chance of success with using these eggs at a later date are much, much better. The law has changed. In the past, the HFEA limitation was you could only freeze your eggs for up to 10 years, but now you're able to freeze your eggs for up to 55 years. So again, this is giving women more control of their fertility. So we also freeze eggs before certain therapies, cancer therapies, and things like that. Surrogacy is a treatment where a couple or a single person may not be able to carry a pregnancy, either because it's two boys in a gay relationship, or a single man who would like to have children as a single man with donor eggs but has no access to a womb. So a surrogate will be able to carry a pregnancy for him. By law in the country, surrogacy is quite limited for some women, but it is possible for a single woman to also have a surrogate to carry a pregnancy for her, as long as her eggs are used. So the intending parent, or at least one of the intending parents, has got to be the source of the eggs or the sperm for the surrogacy to happen. So there'll be two parties, which is a surrogate who is going to carry the pregnancy, and an intended parent who is intending to be a parent and is producing either sperm or egg for the surrogacy. Occasionally, the intended parents may be producing both the sperm and the eggs. So a heterosexual couple who cannot have a pregnancy, either because the woman has had a hysterectomy or may have been born without a womb, they'd be able to use her eggs, the partner's sperm, create embryos, and then put the embryos back in a surrogate to carry the pregnancy for them. There are two types of surrogacy, which is either full surrogacy, where the surrogate has got no genetic link to the pregnancy, so it is someone else's egg and sperm that's created an embryo put back in her. But there also could be a partial or straight surrogacy, where the surrogate is the egg donor. So with all treatments involving stimulation to collect the eggs. So all treatments other than ovulation induction with chlomid or letrozole for those women who've got anovulatory PCOS or IUI, all other treatments, whether it is egg collection to freeze eggs for IVF cycle, to create embryos for surrogacy, all start with the beginning of the cycle or the menstrual cycle. So at the beginning of the menstrual cycle, there'll be a number of potential eggs having been woken up at the beginning of the cycle, and the diagram there represents a number of potential eggs that have been woken up. In the natural cycle, only one of these grows to then ovulate, and the rest die off. With a stimulation cycle for IVF, ICSI, surrogacy, or egg freezing, we will provide some hormones known as a follicle stimulating hormone, which is the same hormone that your body normally produces to get one egg to develop. But if administered to the body as an injection at a higher dose, it will get the egg that would have naturally ovulated, as well as all the other eggs that would have gone to waste in that particular month to grow. And that will be on the right as well as the left ovary. The stimulation process normally takes about 2 weeks. So during that 2-week period, the woman will be having the injections every night. She'll have practical instructions on how to administer the injections at home, and she'll be coming into the clinic every 4 to 5 days for ultrasound assessment to assess how the eggs are growing. As the eggs grow, they'll produce lots of estrogen in the circulation, which may produce some temporary symptoms such as breast tenderness, bloating, but most women would not experience these. So it takes about 2 weeks of the injections. The womb lining will be developing and getting thickened in readiness for implantation. If you're going to have a fresh embryo transfer, we'll be providing some injections to control the treatment so that we don't ovulate before we're ready for eggs to be collected. But once the ultrasound scans show that the eggs are ready for collection, then the woman will have a trigger injection called HCG. Occasionally we use something called Supraca for those at risk of hyperstimulation. And exactly 36 hours later, the eggs will be collected. So it's very important to have a specific date and time to have that trigger injection, and 36 hours later, the eggs are collected. To collect the eggs, the egg collection is done under ultrasound guidance. So we provide an anesthetic, which is called a deep sedation, so you're completely asleep during the procedure. It's not a general anesthetic. General anesthetic involves paralyzing your breathing, so you need to have a tube down your throat to help you breathe with the general anesthetic. But with deep sedation, we don't have to paralyze your breathing. So paralyzing your breathing is an overkill for this procedure. So all you have is an oxygen mask, but you are asleep, you don't feel a thing. Normally takes about 30 minutes for the eggs to be collected. There are no cuts or incisions involved, so it's an internal ultrasound scan with a needle guide. And under ultrasound guidance, we collect the eggs available on the right as well as the left side. And when you wake up in the recovery area, we'll confirm for you how many eggs have been collected. The day the eggs are collected is day 0. If we're freezing eggs, the eggs will be frozen on that day. But if we're going to fertilize the eggs to create embryos, then fertilization will happen on that day. And fertilization will happen either using IVF, ICSI, or PICSI. And the way we'll fertilize the eggs will depend on the quality of the sperm. If the sperm is all 100% normal, then we'll mix the sperm with the eggs and rely on the sperm to swim and fertilize the eggs. So this is an image of an IVF process where the sperm has been mixed with millions one egg has been mixed with millions of sperm. So you can see the big difference between the size of an egg and all these sperm. Once one sperm penetrates the egg will undergo a reaction which will prevent all other sperm from being able to fertilize it. So the best one will fertilize the egg, the rest will be locked out, and that's IVF. If the sperm parameters are not 100% normal, either because of the numbers, the number of normal forms, or the motility or the swimming capability of the sperm is suboptimal, then we will use ICSI. ICSI means intracytoplasmic sperm injection, which means we'll be aiding the sperm, picking one normal sperm to inject into the egg. If proportion of sperm that's mature is low, then we use something called PICSI. PICSI means ICSI, but we'll put the sperm through an extra test to enable us to pick only the mature ones to inject into the egg. So IVF, ICSI, or PICSI to fertilize those eggs. And a day later, we'll confirm how many of these eggs are fertilized. So in most cases, we collect several eggs, put them together with the sperm, or inject one sperm into each egg and leave them in an incubator over the next 24 hours or so. And the next morning, we'll find out how many are fertilized. The incubator is designed to mimic the womb environment in terms of nutrients, temperature, oxygen, carbon dioxide, nitrogen levels, and humidity. So the embryo is in a similar environment to what the womb would be. Confirm fertilization the next morning. The fertilized eggs will then be grown undisturbed in the incubator over 5 days. So fertilized egg, by the 3 days later, it will have divided into about 8 to 10 cells. But by the 5th day, which is the blastocyst stage, we expect this embryo to have divided into somewhere between 125 to 150 cells. The cells will also be differentiated, so you can see a big bunch of cells here that will form the baby, and an outer bunch of cells, they're called the trifectoderm. These will form the placenta, and a fluid cavity over here. Over the 5-day period, a number of eggs that fertilized but had no chance of producing a pregnancy would be dying off, or the growth would be slow, but the best ones will stand out on the 5th day as the best quality embryos to put back in. In most cases, you have several available here. If we're going through a straightforward IVF treatment cycle, we'll be picking the best one to go back in on this day. Occasionally, women may produce too many eggs because they were born with a very high reserve of eggs, or they got something called polycystic ovaries, where if they produce so many eggs, their hormone levels will be so high that the womb's implantation potential will be slightly dampened. But also, if we put an embryo back in and they had a positive pregnancy test, there is a high risk of something called hyperstimulation. So in those cases, at this stage, we will freeze all the available blastocysts and then give it a month or so for the ovaries to recover before we put the embryos back in. So in 2023, all around the world, we're having more and more embryos being frozen to be put back in later, either because of risk of hyperstimulation, but also because of something called pre-implantation genetic testing. In the past, when we looked at embryos under the microscope and they look as beautiful as these, we'd give them a top grade and would use the visual score to grade the embryos and use that as a determination of which one to put back in the womb first. The better it looked under the microscope, the better its chances of getting pregnant, but they could still have a beautiful looking embryo which is genetically abnormal, in which case it would not implant, or if it implanted, it would miscarry. With pre-implantation genetic testing, now we can pick a few cells out of this embryo, send them to the lab to be screened, and out of, for example, 5 embryos, the laboratory data will come back after a few days to confirm that of these 5 embryos, there's 3 genetically normal ones here that could produce a baby. The others were not normal, which will be discarded. So that way we're seeing more positive pregnancy tests, but it will mean that we have to freeze the embryos and wait for the results to come back at a later date. It's treatment that benefits the older women, because the older we are, the higher the risk of genetically abnormal embryos and the risk of miscarriage. But for many young couples, straightforward IVF with putting the embryos back in without genetic testing is still applicable. Any embryos that are not put back in or not frozen on day 5 will be left to day 6, and on day 6 there may be some more embryos available to freeze. To put embryos back in the womb, we normally don't require anesthetic for this. It's the procedure is similar to having a smear test. So the laboratory will prepare the embryos, put them in a culture medium ready for embryo transfer, and you'll come in and ultrasound guidance. We'll get an embryo and transfer it back into the womb. Normally takes about 4 or 5 minutes. We do provide embryo transfers in this clinic 7 days a week. So the embryos will be transferred back to the womb on a day that suits the embryo and your womb, as opposed to a day that's convenient for us. So if your embryo transfer needs to be on a Saturday or a Sunday, the clinic is open for those procedures. Pre-implantation genetic testing is a service that we provide here. Most cases would be pre-implantation genetic testing for aneuploidy, meaning we're testing embryos to rule out the genetically abnormal ones that could not implant, or if they implanted, we miscarry, or if they didn't miscarry, then we may have to consider termination because it's say got Down syndrome or trisomy 13, 18. So by screening those before we put them back in, we increase the risk, the chance of success, but most importantly, diminish the risk of a miscarriage. Then we also provide something called a PGTM, which is a screening for specific genetic mutations. For example, the commonest genetic mutations are things like sickle cell, thalassemia, or cystic fibrosis. So if a couple were both carriers for cystic fibrosis or sickle cell anemia, and we're trying to prevent a baby from having sickle cell disease, we'll be able to have the embryos created. So collect eggs, sperm, fertilize the eggs, grow them in the lab over a 5 to 6 day period, and then do genetic testing on each of these embryos. And the result will come back to tell us which of these embryos are not affected by these diseases, in which case they're the ones that we put back in, and the ones that are affected, we don't put back in. There is also pre-implantation genetic screening for structural rearrangements. So these are genetic structural rearrangements that increase the risk of disease or miscarriages. So some couples may have been tested because of previous recurrent miscarriage, and one of them may have been picked up to have a structural rearrangement. In those cases, we'll be able to do the PGT and rule and screen out the embryos that are affected by these rearrangements, and only put the ones that are not affected to minimize the chance of a miscarriage or abnormalities with the baby. We use an IVF witness system, so it's an electronic witnessing system to ensure that you go home with your embryo created from your eggs and from your sperm. We have never had a situation where the wrong eggs or the wrong embryos have gone to the wrong person. That's usually the worst nightmare for any fertility clinic, but that's because we not only rely on the HFPA mandated double witnessing system, which means 2 people have got to witness to confirm that the sperm and the egg came from a particular person going to the particular person. But we also have an added measure, which is the electronic witnessing system, which was developed in this clinic in association in collaboration with industry, to ensure that your embryos are tagged, and your sperm, your eggs, your embryos are tagged with your identity, and that's way there's no chance of getting a mismatch. If a mismatch potentially were to happen, then an alarm would go off to warn whoever's doing the transfer that they got the wrong embryo. For all our patients, we hope that we do an embryo transfer or an IUI cycle or ovulation induction, and they have a positive pregnancy test. Pregnancy test is normally done around 2 weeks after the eggs were collected, and hopefully it's positive, in which case we see you for your first pregnancy scan 3 weeks later, when chronologically we should be about 7 weeks pregnant. So at 7 weeks, what we're hoping to see on the scan is a pregnancy that's implanted inside the womb. This is what is called a yolk sac, which is what's feeding the baby before the placenta forms. And this is what should be the baby, and there should be a strong heartbeat there. We do offer a second optional scan at 10 weeks. By 10 weeks, the pregnancy is not only more advanced. We can see a pregnancy here with the head, the limbs are formed, the baby is moving around. But most importantly, the baby's placenta will also be producing lots of the baby's DNA into your blood circulation. So from a simple blood test from mom, we'll be able to get the baby's DNA and screen for the common chromosomal problems to a 99.99% certainty without interfering with the pregnancy. So we don't have to get needles into the pregnancy anymore to get this information. We can get it from a simple blood test from mom's arm. The test is very, very accurate, but it also screens for sex-linked chromosomal problems. So for those who want to find out the sex of the baby by as early as 11, 12 weeks, when you get the results, it will be able to tell you whether it's XX or XY chromosomes. But if you don't want to find out, we could still perform the test, but the lab will withhold that information from you. You'll find out when the baby is born. Most of our fertility patients here would be self-funding, which means they're paying for their own treatments. But we also have some NHS contracts. So for those who are eligible for NHS-funded treatment in the Mid and South Essex Integrated Care Board, which is patients from Mid Essex, Castle Point and Rochford, Basildon, Brentwood, Thurrock, South End, if by the criteria of that or the particular Integrated Care Board, you're eligible for NHS funding, then you'll be able to select Herts Essex as one of the as a clinic to have your treatment in. The different areas have got different criteria, so they've got age cutoffs, they've got BMI cutoff. Most of them would not fund you if you had a child before, so it's got to be almost always for the first child. You need to have been having difficulties getting pregnant for over a year, and if on the basis of those you're eligible, then your local NHS hospital will tell you that yes, you're eligible, and then we are one of the options for you to come and have treatment here. For patients who live in North Central London, so that's Barnet, Camden, Enfield, Haringey, Islington. Again, if you're eligible for NHS funded treatment and you're registered with a GP in those areas, then you can have your NHS funded treatment here as well. We do have other funding options. So some of our patients will have free IVF treatment in something called an egg share program. So these will be young women who have got above average reserve of eggs, looking to have fertility treatment, but also looking to share some of those eggs. So for example, someone produces 16 eggs, they'll have their IVF treatment for free, use 8 of those eggs for their treatment, anonymously donate 8 eggs to help out, and that way they get all the treatment for free. We have a sperm share program as well, and also something called a freeze and share. A freeze and share is where women who are looking to freeze their eggs or freeze embryos for the future, but looking to help out as well, but also to subsidize the treatment, almost 100%, would have the treatment for free, freeze half the eggs for their future use, and donate to the egg bank for those who are looking to use the donor eggs. So whoever's going to use the donor eggs will fund your freezing treatment or your IVF treatment in that case. The clinic will never approach a patient to ask them to donate their eggs or to share their eggs. It's got to be the patient or the couple who approach the clinic for more information. We give you the information, you think about it. If you want to donate, we insist you have to have independent implications counseling, and once and you got to understand the implications before you're allowed to be a donor. So the emphasis is on the altruism of it. It's got to be you're donating because you want to donate and not donating because you want to have the treatment for free. So occasionally we pick up scenarios where someone is more driven by the financial side of it as opposed to trying to help out. And in those cases, I'll tell them, we don't think it's the right thing for you because you may regret it. It's got to be someone who's looking to donate to help out as well. The costs of the treatment vary depending on the treatment you're going to have. All our costs are available on our website and they're up to date, but also when you're coming in for your initial consultation, depending on the treatment you're going to be having, you'll be given a specific breakdown of what treatments will apply to you. You will get a specific invoice from finance team about which treatment you're going to have, what it will cost, and then that helps you to plan as well. We use Access Fertility. Access is a finance company that sits outside of the clinic. They do have fertility programs to include things like IVF Unlimited, where for a certain amount of money you pay to Access Fertility. They will cover as many cycles of treatment as you can fit in a 2-year period to at least get to a baby. If at the end of that period you've not had a baby, they'll refund that whole amount of money to you. They've got some 2 or 3 cycle refund packages, as well as multi-cycle packages. I think the timeline is that by sometime in October, November, they will also be rolling out a finance scheme. So they could, it's almost like a loan scheme, so that you don't have to fork out that money in advance. They'll be able to loan it to you, but I think it most likely will be at a small interest. But that's not available yet. It's going to be rolling it out later in the year. We appreciate that these treatments take a lot from you, physically, emotionally, financially, and the stress of infertility, miscarriage, and recurrent pregnancy loss means that you need some support. We do provide free counseling for all our patients, but also provide a support. One of the best support is from your fellow patients. So we've got a support network, which is moderated, but you've got access to several programs. We would signpost you to support for donor conception network, surrogacy networks, and all of that. So depending on what path you're on, there is a support network for you. We provide fertility-specific dietitian support. So we've got a dietitian to work with who's available for one-to-one consultations. So why us? We've been doing this for a long time. We've got a service that runs for you, not for our convenience. And our main ethos of this clinic is, we are realistic that not everyone will get pregnant the first time round, and we're also aware that for some it may take several goes before they have a baby. Unfortunately, for some of our patients, they may not even get to have that baby. But our main emphasis is that in the course of that journey, the experience should be as pleasant and bearable as possible. So your emotional well-being, your dignity, and your independence is of utmost importance to us. And that's one of our driving things, is that, it is stressful, but we try and ensure that for every one of our patients, that journey is as pleasant as this can possibly be. There's nothing pleasant about having difficulty getting pregnant, but it shouldn't be very clinically driven, heartless process. We value your feedback, so we'll send you some links to get us some feedback. Connect with us on social media. For those who are looking and happy to book a treatment with us or to book an appointment with us, we got our telephone and email contact details. So when you're ready, give us a call. On average, from giving us a phone call to book a new consultation to getting booked in is usually about 4 weeks, and you're always looking at about somewhere between 6 to 8 weeks from booking a consultation to starting your treatment. By all means, I think we've been looking through and answering your queries on the chat line, but we'll look, and if there's any common theme questions, I'll answer them. But we'll hang on at the end of the presentation and answer as many of your questions as we can. We'll also get your virtual tour of the clinic at the end of this. Thank you for your time, and we'll be around for another 25, 30, 40 minutes to answer any questions that you have.